Hi, so this is a talk about my forthcoming pre-conference workshops in Mexico in October. So the Mexican National School of Osteopathic Medicine, hello, is having a great conference about the clinical applications of osteopathic medicine in women's health this year. And they asked me to do 2 days before the conference for a workshop on obstetrics. So I'm just going to give you a quick overview of all the things that we might be able to cover and sort of cram into those 2 days. So with obstetrics, it's all about everybody being viewed in their own merit, so to speak, and there are many different shapes and sizes of pregnant women, and this is actually from an Australian physiotherapy study on pregnancy, but so it's nice and warm there, and hopefully it'll be nice and warm in Mexico as well. But it's all about how pregnant women start out, so how they manage to grow and adapt and how their bodies change can often be influenced not just by the baby within, but how their own body has got pre-existing tension patterns, say if their thorax is blocked or if they've got a problem with their hip or cervical spine. All of these other non-pregnancy related disorders can obviously give you a structure which is not as three-dimensionally pliable and as flexible as it can be. And that's what you really want to look at. You want to sort of see through the current pregnancy, see what's going on in terms of what is in her already that could limit the natural and ongoing changes within her body biomechanics that she's going to have to absorb. So we certainly go through a whole variety of normal spinal curve changes in pregnancy and how different sections of the spine do different things at different times, and how when you move, for example, the side bending movements are the ones which are the best preserved throughout the pregnancy. So we talk about some research to do with what changes where, but it's not so much just her spinal changes. It's very much a three-dimensional thing, as we'll see briefly. But we look at how the body changes. We also look at bits to do with the fluid dynamics, circulation in pregnancy, and some other physiological changes which are useful for osteopaths to know about. And we also look at the different trimesters, so first trimester, second trimester, third trimester, and I certainly want to try to dispel a few myths. And I certainly want to, for example, talk about the first trimester. Should you, or what's advisable to do in the first trimester? Should you do any work? Shouldn't you? There's some very conflicting views out there, as we can see, and there's some idea about, well, you know, if you avoid the dates of what would have been your first missed period or your second missed period, then you're fine. But you know, we'll see that there's a whole load of stuff around that which becomes confusing. But depending on what you are trying to achieve in the first trimester, there may well be things that you can do. But we're also then going to look at throughout the rest of the pregnancy in the second trimester, and also third trimester preparation for labour and delivery. Now, one of the things that's really interesting osteopathically is that we really get this opportunity to try to help the mum to integrate into her ongoing pregnant state and her forthcoming dynamics. So it's much about how she begins to both absorb, but to consider, you know, mentally for herself what's coming up. She may well have had experiences in the past. She may well not want to try to have the type of birth she had previously, or she may well be worried about what her future birth could be if she's not had one before. So there are a whole load of mixed emotions and so on. And so there's a way of looking at mums, whatever their prior experience, whatever their prior biomechanical pain pattern and problem history may be, as to how we can look at their concepts of fear and emotions and memories and so on. So we definitely want to try to get into that. We also have a whole range of techniques that we can do, either if you're not very pregnant compared to when you are very pregnant. And we both look at the front through all the visceral cavities. We look through layers and ligaments, but we also look at the posterior parts of the pelvis, the ligaments, and we also point out that actually all of the usual usual biomechanical stories of pelvic axes and sacral, left on left, right on right, all that stuff, or MET, piriformis, do this, do that. Look, throw it all out the window. Look, awfully sorry, guys, but it doesn't work that way in pregnancy. So those models were not in relation to how a pelvis should be deformational, adaptable, compensatable, and it certainly doesn't describe what happens when you get a three-dimensional torsion pain, torsion strain from some sort of postpartum recovery dynamic, having gone through some sort of complex obstetric trauma. So you sort of got to put your head aside for what you've learned previously and actually learn a more integrative dynamic, which allows much more possibilities, both for compensation, but also for trauma dynamics. So when we start to look at the way that the pelvis moves in pregnancy, we absolutely can't separate it from the lower limbs. There's all sorts of other things you can't separate from diaphragm, mediastinum, up through ventral throat, jaw, etc., etc. But critically, the role of the legs with the ilium in the pregnancy biomechanics, really important to get a handle on. And we look very much at this three-dimensional dynamic of how you get shape changing going on, and the role of the pelvic floor as a prime mover of pelvic bone mobilizations, for example. So there's a whole load of things that we can do. And then we've got a load of tests that we can also look at, how you move things about, how you can tell where the problem is, what's your screening protocol, what do you do at different stages of the pregnancy, and you know, what are you going to consider as indicative of something. So we look at that both for the pelvis, the spine, we look at how the pregnancy can be considered in the abdomen and so on. And we certainly absolutely think of the fact that you've actually now got two patients, well, maybe even three, depending on how many babies mum's carrying, but you don't have the same luxury of being able to talk one-to-one with your patient, because you've got two of them, and one of them you can't talk to directly. You have to look at that patient with respect to its relationship with its mum's body. So this whole idea of space, orientation, alignment, interaction is key for things like optimum fetal positioning, and understanding how the baby pushes out and so on is really a big part of what you need to consider. And this whole story about, you know, this ligament does this twist, uterosacral ligaments do that twist, you know, these torsions on the uterus, it's all well and good, but I think there are some really serious problems with it as a rationale, because apart from anything else, the uterine muscular wall and the ligaments that attach to it, it's separated from the baby because of the membranous sac. And so you actually get a completely separate individual movement, not only with the membranes and the uterus, but also from the baby itself within its membranous fluid-filled bag. So the capacity of the ligamentous dynamic acting onto the uterine muscular wall, ending up absolutely onto the fetal dynamic, I think has something that we've got to question, because I don't think it's valid in all cases, and many dynamics are actually going to arise earlier. So there's lots of things that we can talk about that. Certainly, though, a space eventually becomes a premium, and if we have a look at this little x-ray, we can see absolutely that with the head of the baby down here, there isn't a lot of space between those two ilia, and so every time the mum is walking, it's working on the baby's head and mobilizing. So there are ways of doing techniques in later stages of pregnancy which avoids putting too much pressure on the fetal parietals, for example. So we look at how this dynamic of actually understanding the gait and the pelvis and the space for the baby and the presenting part from a limb perspective. And this limb perspective also helps us understand things about symphysis pubis, about diastasis, about anterior pelvic girdle pain, but not only the anterior, but how that interacts with the stability of the posterior lumbosacral dynamics. So we talk about all of that sort of stuff, and we also try and get in an understanding of the process of labour, process of delivery, what the baby should be doing, but not just on the impact then that would have on the baby, but what that would then show for the dynamics of the maternal pelvis. So yes, we want to give the baby an easier ride, but also we want to understand how, if we can prepare mum's pelvis, hopefully we can mitigate issues, but also we can then understand the three-dimensionality of any birth trauma that may have ended up arriving. So yes, we certainly look at the pelvic floor and its layers, the roles that it should have, what's trying to happen, what about prepartum strain patterns in coccyx and things like that. We talk about that. We then also look at how we have this dynamic and interaction between the hard and soft components of the birth canal. And we can obviously look at pelvic floor injuries, we can look at pudendal nerve irritabilities, we can look at episiotomies, and we can look at a whole host of techniques with respect to this, making sure that we've done everything to give the mum possibilities. So therefore we can leave the mum at the end of her pregnancy with this idea that she's done what she can do. She's prepared, she's eased things out, she's removed barriers and hesitations and so on as much as possible, that the biomechanics are not limiting, or at least as they're limiting in as little a way as possible, so that whatever then happens with the forthcoming delivery, whatever delivery she ends up having to have, that the hypothetical dynamics of the possible theoretical impacts that that could have on that delivery, that as osteopaths one's done as much as one can do, because one obviously can't predict. You can't say that, well, if we do this, this won't happen, or if we do this, this will happen. Nothing's like that in childbirth. It's simply not a push button recipe thing, and there's so many factors that are involved in labour and delivery, which we'll attempt to go through a little bit of, but we're at least going to try and give you some dynamics that we can, that you can have as an evidence base, that you can have as a rational approach, which busts a few myths, but gives you something which is has a solid foundation and a good basis, and that you can communicate that to the mum with the aim that you leave her less stressed out about what's going to come to be with the labour and delivery. Because the best thing that you can do as an osteopathic approach in obstetrics is to remove maternal stress. Full stop. Removing maternal stress is the biggest beneficial factor that you can do. So if she goes into that labour and delivery less distressed about what could happen, less worried about bits of her body, more comfortable in her body, you've done as much as you can do, and that is an excellent job, so that the midwives and obstetric team can then help her through the rest. So look, I'm hoping to cover hips with you in these 2 days of this pre-conference workshop. We'll do what we can in 2 days, because obviously it's a huge subject. But yes, so coronavirus aside, I shall be with you in October, and we'll have a good workshop then. So see you then.